should give you an idea of what a multiplicity is. But first, without me going through it, I want all the students, I need you to take a vow in advance. So I need everybody to raise your hands. All right, I need you to repeat after me. I fill in your name. Excellent. Will never overreact to a subgroup analysis. All right, so let's see. So multiplicity. So what am I talking about here? Generally speaking, a multiplicity is any time you are looking at either the same thing multiple times, or you're looking at multiple different things, and you do that in some kind of statistical mechanism. You're always at risk of finding essentially results that are due to noise rather than anything that is due to signal. So the kind of thing that I want you to keep in mind throughout this lecture is whenever you see a result, so whenever, reading a paper, this is a p-value, this is what it is, I want you to always kind of think critically about it and think, how did this get to me? Is this the only thing that somebody looked at? Was this written in the protocol in advance? Or is this the result of some kind of fishing expedition where lots and lots of stuff was looked at? So I'm going to talk about ways to recognize these things, what their consequences are, and how to mitigate them. So, as I said, basically there are two forms of conducting multiple tests, which you're going to find over and over again. One of them is testing multiple hypotheses at once. So if I run a study and suppose I'm looking at stroke and I go, all right, well, I originally thought I'll look at 90-day MRS for a certain group of people. And now I get the results and I go, hey, well, that didn't work. So, the p-value is 0.2 or whatever the case may be. But now I'm also going to look at a whole bunch of other things. I'll look at a 60-day endpoint, a 30-day endpoint, and I'll look at people who had severe strokes. And I'll look at people who got my treatment early after their stroke versus late, and I'll split up the data. I'll look for people who are older. I'll look at people who are versus men versus women, and so on and so forth. And gradually, when you end up with this list, you end up, I've looked at 40 different things. And a lot of times it's more than that. As a plea from your friendly local statistician, please don't make us look at too many things. So we don't like that. Charity, do you like looking at a lot? Definitely not. So anyway, limit your number of analyses. The key issue is, whenever you do this, something's going to randomly show up as being valuable. If you look at 40 things, there's going to be noise in your system somewhere. Some group of people are going to look good. Some time point's going to look good. And it doesn't matter whether your drug can do nothing, and you're going to get lucky if you look at it often enough. The other thing that can happen here is if you test the same hypothesis multiple times. And this is largely, I don't want to steal Chris Coffey's thunder from tomorrow, but generally speaking, there's something called a group sequential design where I say, okay, I'm running a trial, it's going to take 3 years and enroll 300 patients. Maybe I'm going to get an answer earlier than that. So can I look at the data at 150 patients, 200 patients, 250 patients, and 300, and get an idea about, hey, can I just stop the trial when the answer is clear? That intuition is not bad, but you do have to be careful of the fact that because you're looking at this data multiple times, you can also get the same kind of spurious conclusions. If you look at it over and over again, it's possible at one point you could be getting a lucky result, and you don't want to overreact to that lucky result. Chris is going to talk about some ways to do that right, as opposed to ways that set you up for problems. So the kind of thing, the classic thing, if you think about ways that phase 3 trials can fail, one thing that happens over and over again, you run a trial, you get a p-value of 0.11, it's not successful, and you go, oh, all right, so that was bad, I'm depressed. And now what you do is you go through these 40 analyses that I did before, and And so you find out things like, oh, if I just looked earlier at a different population, and then what happens is, and people come to us all the time with this result, goes, oh, I now know where the drug works. I was sure it worked beforehand, but my trial didn't get a significant result, but now that I looked at the data in 132 different ways, I now understand how the drug works. So I'm going to enroll this specific group of people, look at a different endpoint, and so on and so forth. What invariably happens when you do that is the follow-up trial will also fail. And the reason for that is whenever you look at, as I said, there's noise attached to everything. So let me just repeatedly say, if you're looking at 40 different analyses, some of these 40 different analyses are randomly lucky. They're random highs that make the drug look good. Also, you shouldn't react. There are random lows that make the drug look bad. Kind of as a side point here, a lot of times when we are going to the FDA and we have phase 3 results, the FDA will also bring up, hey, we looked at 6 or 7 subgroups and this one doesn't seem to be doing as well. Should we worry about that? Should we make the label be more restrictive than what we might otherwise do? And so this is that problem in reverse. You don't want to overreact to the highs, but you don't want to overreact to the lows. It's quite possible that group randomly didn't do as well in the trial. So, all right, do not focus too much on the highs. All right, so kind of a layout of what the multiplicity is. I'm going to get a little more into detail about where they come from. So this gets back to the group sequential strategy. I'm not going to, trying not to steal Chris's thunder. Usually I give this talk after the group sequential talk. So now I've got to do this. Maybe Chris could just give this talk. This was all done yesterday. Okay. But anyway, suppose I look at the data repeatedly. So I look at it at n equal 100, and I say, oh, is p less than 0.025? If n is equal to 200, now I look, is p less than 0.025? And I keep doing that, 300, 400, 500. There's a neat statistical fact that even if your drug does absolutely nothing, if you look at the data over and over and over again, and you've got this p less than 0.025, even if the drug does nothing, you will eventually get a significant result. It is a guarantee. Might be a while, but it is a guarantee you will eventually get a significant result. So generally speaking, we don't do this. We don't test at 0.025 because all these errors are adding up. The standard thing that we do is all of these individual tests, they happen at a level that's lower than 0.025. And we use a lot of clever math so that the odds that we make any mistake at any of the analyses is still 2.5%. So that's more of a preview and an ad about what Chris is going to be talking about. So I talked about subgroups and how you'll often have issues with overreacting to subgroup analyses. Multiplicities can happen in weird ways. So I do a lot of consulting in an area called historical borrowing. There's an FDA guidance on this that just came out in January, essentially covering this. But essentially what this is about is you have historical data from other trials. So maybe a bunch of people did trials that investigated your control arm, and now you want to compare to a novel treatment. So if you think about the totality of the evidence, you're going to have your treatment arm from your current study. You've got your control arm from your current study, but then you may have all this other information on a control arm from external places. So the question is, can you use that? I'm not going to talk about the ways that you would do that, but there are some risks and benefits to doing this. So I had somebody come to me at one point, and so they said, I want to do this. And I want to borrow some data from one of my phase 2 trials. And so they gave me all the data, they handed everything out, they said, here's everybody we're going to enroll. And so I started doing the design. This is actually a very bad thing to do because I did not ask the right questions. So anyway, so I started probably a week, 2 weeks into this, and then eventually they said something and I realized that I had gone down a bad path. And so I asked them the question, is this the only data you have? And they said, oh no, our phase 2 trial was much bigger than this. And then they went through all of the different analyses. Turns out their phase 2 data didn't look very good. So they did lots and lots of different analyses. And then what happened is they found the subgroup that they had the biggest observed result. It's likely one of those random highs. And then what they wanted to do was they wanted to borrow that data into their phase 3 trial. Well, that doesn't fly because what you're borrowing in, if you're borrowing the best group out of a lot of different analyses, that group is likely biased high. And that's bad because if you are bringing in a biased thing into your study, you're actually rigging the game in favor of your therapy. You increase the chance of making a false positive conclusion. So at this point, we had some discussions, and they ended up not wanting to work with me anymore. So anyway, I wasn't going to deliver any benefit because I basically told them there's no way you can say this with a straight face that this makes sense to do. And usually that doesn't go well. So anyway, so you don't want to do that, but you always want to ask. This happens in papers that you read as well. If they haven't published a protocol and actually said, hey, this is the primary analysis, if you read through papers, you will often find that they report, they say, hey, this was our analysis, but you look back through it for like, that wasn't the primary, it wasn't the secondary. How did you get to this? And they don't tell you that this is the tip of a very big iceberg on this. So that happens over and over again. And also, if you look at drug company press releases, they do this all the time in terms of, oh, we found a great effect on endpoint X. Was that your primary? No. Was that your secondary? No. Was it your, which one? Tertiary? No. Was it an exploratory? Well, it's the 5th one. So anyway, this happens a lot, and you should weigh that result in context. If they had to look for their 5th exploratory endpoint to find something valuable, take that with a grain of salt. Now, don't go too far the other way. You know, if the p-value is 0.000000001, there is reason to be hypothesis generating in these cases, but don't view yourself as having a tremendous amount of confidence in this. There's also a question of how broadly should we think about this. And this is always an interesting thing when a client comes to me and they want me to design a phase 3 trial for them. I know that they are usually sitting on good phase 2 data. Because if they weren't sitting on good phase 2 data, they might have abandoned the program and they wouldn't come to me at all. So I naturally assume that every client who is going to come to me, their data is biased high, biased good, to at least some degree. And I'll leave you with a philosophical point. They actually might think of it exactly the opposite of, especially if it's a small biotech, this is the only trial I've ever run in my life. So they don't think there's a multiplicity, but I do. So anyway, that's an interesting question of your perspective on things. So, but we always try to get an idea about, is this, how did your data come about? What else did you look at? What's the totality of the evidence to get an idea about should we believe it or not? Okay, so all of these things are going on. Multiple tests result in biases. You should always worry about those. So the question is, going into a study, what can you do to mitigate this? Many of these are required by regulators, they're required by journals. If you publish a clinical trial in JAMA or New England Journal of Medicine, they want to see what was the protocol, what's the primary analysis. They're going to be on your back about making sure you're reporting things accurately and not in a cherry-picked way. So the first step to this is one of the reasons that we have primary analyses in the first place. So this is supposed to say, this is the endpoint that we care the most about. This is the one, there's no multiplicities attached to this. This is the first thing that we're going to look at. And then at that point, we have secondaries and anything else that goes on that. But being able to write it down in advance and being able to say, this is the first thing we were going to look at, as opposed to the 10th thing that we were going to look at, That's trying to say in advance, the first thing that we look at, if we got that one to be a success, that's more credible than if the first 9 things failed and the 10th thing happens to be the one that won. So pre-specify your analysis. That's why you want to write everything out. And pre-specifying is not just about endpoints. How are you going to analyze it? The discussion yesterday on missing data. How are we going to handle that? All of this needs to be written out. Even something like missing data, if you have 10% of your data is missing, hey, you can go look, I'll try 5 different missing data methods and maybe find one of those 5 got me the results I wanted and the other 4 didn't. That's also a multiplicity that's coming in. So write this out in advance. I virtually guarantee that something is going to go wrong in your study. You may not be able to follow that plan exactly, but having it written out in advance and documenting, hey, here's what I had to change and here's why, is helpful for the interpretation. The other thing that you do here is you need to adjust your criteria for success. If you're going to look at multiple things, you can't look at 10 things the same way you would look at 1. We talked about the group sequential example. If you're looking at the same hypothesis over and over and over and over again, then what's going to happen is you need to have different p-value thresholds. They're not all 0.025. So some of them are much lower, and so we try to make sure in the aggregate we do that. That's Chris's tomorrow. I'm going to spend a lot of my time on what happens with if you have multiple endpoints. So suppose that you're looking at, I've got 3 different endpoints and I want to correct for them in some way. Okay, so now what do I do? All right, well, I can't test them all at 0.025 because something may randomly win. So the simplest thing to do, most people hear about in some stat course along the way, is something called a Bonferroni adjustment. And it basically says if you have 3 endpoints, you take whatever your alpha is, 0.025, divided by 3, you test each one of those at 0.025 divided by 3, and I should have picked something I could actually divide by, which I did in the slides. So if it's 5, 0.025 over 5 is 0.005, I can do that one. So anyway, but you keep that in mind, you test at a lower level. In general, this is the simplest thing, but this is actually not what people do in modern practice, unless there's a couple, anyway, there are some exceptions to this, but there's lots of fancier things. The problem with Bonferroni is that generally it's too conservative. It over-adjusts for the multiplicities. You don't have to adjust as much as a Bonferroni does, and you can still protect yourself against multiplicities. So people have been working on this a lot. One strategy that you will see is gatekeeping. And gatekeeping is often used when you can order your endpoints. I have a primary endpoint, and then a key secondary endpoint, and then another secondary endpoint, and so on. If you can order your endpoints in terms of importance, what you can do is you can say, okay, I'm going to come in, Mark is going to be my primary endpoint. And
Take enough notes, though.
well, I didn't say you had a significant value. So anyway, Emily is our secondary endpoint. Emily's notes are fantastic. So what's going to happen is in a gatekeeping approach, we say we're going to test our primary endpoint Mark and decide was Mark significant or not. If Mark is significant, we go, woohoo, we want her study. And at this point, we can go and test the next endpoint in the order. So now we can test whether Emily was successful or not. If Emily is successful, we can move on to Nicole, and back to Roy, and back to Charity, and we can just keep going down the list. Now the issue with gatekeeping is in order to protect ourselves from multiplicities, we also have to be sure that if somebody doesn't win, it's a chain. If somebody breaks the chain, it's done. So if Mark didn't take good enough notes, his p-value was 0.2, it doesn't matter that Emily's p-value is 0.000001, we can't test Emily. So she is not significant according to the gatekeeping rules. So I'm sorry, I think the world of you, but you wouldn't get that. All right, so anyway, so that's one strategy, and the advantage to this strategy is you'll notice I get to test all of these things at 0.025. As I go down the list, I can keep doing my alpha. The disadvantage to this is as soon as I run into a negative result, I can't test anything else. So there's a limit to how many conclusions I can draw in this. As you can imagine, there's a bit of gamesmanship in how to order all the hypotheses. So it may be that, oh, I'm really confident charity's going to win. We might want to move charity up in the list, so we make sure we get the test in before we start to risk not getting one and we can't test anything past that. So there's risks and benefits to this kind of gatekeeping strategy. A more complicated version of this that people have used is something called graphical methods, which I do not have time in any length here to do justice. But essentially the idea behind graphical methods is I can kind of get the best of both worlds on this Bonferroni and this notion of gatekeeping. So now what I do is I say, okay, Mark's really important. Emily is also important. Now what I'm going to do is I'm going to split up my alpha. I got 0.025. I got this pot of alpha that I can use. And I'm going to split it up between Mark and Emily. So at the beginning, I'm going to give Mark 2% of it, and I'm going to give Emily 0.00% of it. You can split it up any way you want. You split it equally. Why people would do one thing or the other depends on how they view the endpoints. I've had a sponsor where they're putting the 0.02 on what they consider the more important endpoint to be. It's what they really need to win. I've also had sponsors, they might actually view Emily as important as anything else, but they view Emily as they're going to get a stronger signal. They're more confident they're going to win on that endpoint, so they give less alpha to it, still in the hope that they're going to win everything. But in any case, we've got this alpha split up. Mark has 0.02, Emily has 0.005. And now what I do is I now draw a graph. So now what happens is if Mark wins, so if Mark was successful, he now has 0.02 alpha. We can reuse the 0.02 alpha. It's an interesting math result on why this is true, but now Mark can say, I'm going to pass my 0.02 to Nicole, and now we can test Nicole. And so Mark can pick this up. He can divide it in any way he wants. So Mark could say, I'm going to give 0.01 to Nicole, and I'm going to give 0.01 to Roy. But basically, anytime you win a hypothesis, you can pass the alpha on to somebody else. And Emily can say the same thing. So anytime there's a successful test, you can percolate the alpha forward. Now, if Mark were not to win, so if Mark was not successful at 0.02, then Mark eats the alpha. It's like a whole big fire happens around Mark, and he's consumed, and his alpha disappears with him. And so it's just gone. So you don't want to trust Mark with alpha unless you're confident he's going to win. So anyway, you can imagine that there are, you can make a very complicated network where divide up your alpha and percolate it any way you want. Modern pharma companies, if you look at a major phase 3 trial right now, they write out lots and lots of these kind of graphs. And the reason that they care about them so much is anything that you have type 1 error controlled, you can put on an FDA label. So they want to be able to say that our drug affects the following. And the FDA insists if you want it on the label, it's got to be there. So you can imagine the drug company goes, I want the label to give us this, 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 and this, so we can distinguish ourselves from a competitor drug or whatever the case may be, and so they play this kind of gamesmanship game. I don't think you're going to have a lot of case to do this in your trials, but keep in mind that as you read papers, this is going on in the background. This should be in their protocol somewhere. You'll see a graph that does this. If you ever read a paper by Eli Lilly, they have the most complicated graphs I've ever seen in your life.
Kert,
Yeah.
are like a pharmacy company, are they taking, let's say, model data and constructing these alpha pass-throughs in a modeling way to pick the best strategy, which order they're going to do them?
Absolutely. So they will go through all of their phase 2 data, and they will model what do we think is the likelihood we're going to win each of these endpoints, including the correlations between them. Because a lot of times, hey, if I can win a certain endpoint, I'm likely to also win mortality, for example. Those things have to go together. You know, if you're doing an MRS, mortality is part of the MRS, so they're correlated with each other. But yeah, they would go through and they would essentially look at a wide variety of graphs and calculate what is the odds I get different kinds of labels based on different ways of constructing this graph. And it's the computers will turn on this a long time, and that's exactly what they're hedging against. All right, but for your cases, I would do simple things. So this gatekeeping approach, the gatekeeping approach is actually just a very special case of what I did before. Give all the alpha to one endpoint and just line people up. One endpoint wins, go to the next one. If that endpoint wins, go to the next one. It's a common strategy. Or do something like Von Ferroni. If you have a complex web of endpoints, consult your friendly local statistician. All right, let's see. Okay, so let me kind of give a couple other things. This doesn't come up in clinical trials, but you'll see it in papers. A lot comes up in some clinical trials, but not many that we'd be working on. I certainly don't work on many of these. But there's something called a false discovery rate. And I just want to emphasize the difference between that and the kind of type 1 errors that we're talking about. A type 1 error says that if your drug does nothing, if it's a null, what is the probability that you're going to claim success? And so typically we need that to be 2.5%. A false discovery rate looks at something quite different. It says, suppose I look at a lot of different things and I'm going to declare success on a number of them. For example, I look at the typical place you'll see this is in some kind of genomic analysis. I test 10,000 genes. I want to know which are associated with an outcome, and I find 100 of them come back significant. In a false discovery rate, your question is, it's not, given the drug doesn't work, what's the chance I claim it does? It's the reverse. Given that I declare success, what is the probability that my drug works? And those are very different questions. So the probability you are male given you're pregnant is very different than the probability you're pregnant given female is very different than the probability of, I can't even remember what I just said. The probability that you are pregnant given that you are female is different than the probability that you are female given that you are pregnant. Those are not the same numbers. Those are very different. Now, male and pregnant actually, but unless you're a sequence. All right, so let's see. So anyway, just keep in mind if you see that as a different kind of quantity. The other place that you will see where this is different, master protocols. So there's a lot of trials these days that are investigating multiple therapies all at once. There's a stroke trial called STEP. There's lots of COVID trials. There's panoramic principle, anti-cove. There's an ALS trial called Viele, which is investigating multiple therapies. But in these kind of trials, they build a large infrastructure and they test multiple drugs within that infrastructure. Generally speaking, in those settings, you don't have to worry about the multiplicity. Even though you're testing 8 drugs, the FDA will not ask you to take a multiplicity penalty. And the reason is that platform trial is intended to replace separate trials investigating each drug, and we generally don't require a multiplicity penalty for multiple companies investigating different things. So we don't tell Merck, for example, oh, well, you're investigating that, but Lilly is, and AstraZeneca is, and Amgen are investigating this, so now you have to take a penalty. Generally, we don't do it. There's an argument maybe we should, but generally we don't. And so if we're not going to do it for separate trials investigating the 8 drugs, we're not going to do it for a platform trial investigating the same 8 drugs. So you'll see some things there. All right, so let's see. To make sure you all get a break, remember that multiplicities are everywhere. So the key, if you remember nothing else, don't worry about remembering any of the methods. Just always keep in mind, whenever you see a result, what am I not seeing with this? How many analyses took place? How many things were looked at? How many times was something looked at? All of those things have an impact on how credible that result is. And a lot of times they won't tell you what that is. So you have to basically have you have to kind of have a bloodhound sense of, I bet it's there and I'm not looking at it. The key ways that we deal with this: pre-specify everything, make sure people can go back to your protocol and assess how many things did you look at. Well, it's in the protocol. I saw what order they were going to do this, how many things they were going to look at. That's very helpful in saying, you know, maybe the p-value of 0.000001, yeah, you looked at 10 things, but that p-value is really small. They pre-specified everything. It's still probably a credible result. And then keep in mind there are a wide variety of statistical mechanisms that go from the simple Bonferroni gatekeeping to the complex, those graphical methods, which if you're doing lots of endpoints start to have more value. But people have given a lot of thought to this, and there's a lot of clever ways to handle it. But basically realize this problem exists and take measures to address it. All right?
Questions? Any?
Just curious, you gave an example of how it's not appropriate to use historical borrowing. In what context is it appropriate?
Well, so we've done a number of these. So you're going to get controversial answers here. Some of the easiest examples, if you do an antibiotic trial against a new antibiotic, in many cases, so if you do like, I'm going to give you a really specific example, like a complex UTI, and you're doing, I'm going to forget what the antibiotic is. The standard of care for complex UTIs, which I do not remember off the top of my head, I do know, however, that essentially the cure rate, if you look study to study to study to study, they're all around 80%. It's like 75 to 85 in every single study. It is reasonable to say I'm probably going to have a result between 75 and 85, and bringing that in will give you more precision on your treatment estimates. Obviously, if you run your study and yours has a 60% rate, that's going to be some cause for doubt. Fortunately, there are actually some statistical methods to mitigate that. They recognize things aren't there. They're not perfect. But those would be the kind of examples. Places where the control arm's been investigated for years. We've run 100 Alzheimer's trials. We've got a lot of idea what the natural time course of Alzheimer's is. So those kind of situations make more sense.
So Kurt, that was wonderful, and I think you really exemplified why, if you're going to do a clinical trial, you need to come to a statistician who's an expert in clinical trials. Because I work a lot with geneticists, and I work a lot with computational artificial intelligence, and their statisticians look at the world very differently. You talked about false discovery rates. And the problem is that the scientists they work with don't understand that they approach it differently, as you expertly explained. So that when I start talking about pre-specify everything and have gatekeeper approaches, they're like, oh, you're the clinical trialist. And but if you're going to do a clinical trial, not every statistician is the same, and I hope that's really come out through his talk, which was really wonderful, because you could go down the wrong path if you get it. Not statistical geneticists are wonderful, but they don't look at the world the same way.
Can I ask, did the Aduhelm violate every principle that we discussed here?
No, so
Alzheimer's antibody trial?
aducanumab, the issue with aducanumab is the futility rule. And I think actually, I'm gonna make one plug.
There's a subgroup analysis and there was
No,
retrospective
no, they
and.
had two different studies and their futility analysis borrowed off between, anyway, we have a podcast, we go to Barry Consultant's podcast, which I hope is not advertising, we get no money off of it, I swear you don't get money off of it. But anyway, we have a podcast on how to get around.
Okay, I guess one more question. You ready? Back. Oh. Who's first?
Kert, great talk. So, one of the comments about the graphical method you mentioned. So, you mentioned about like how we are recycling the alpha, right? Like if one of the endpoint needs the alpha, we are just giving it to them. But there is also the power, right? Like that might kind of impact the power for that particular endpoint. So, do we need to consider both at the same time?
Yeah, and that's what Mark was, I think what Mark was getting at on, you need to write out and consider how you're gonna gain that system. The advantage to all these methods is that they do control the type 1 error. You get family-wise control of the type 1 error, you're not making false conclusions. But you also, by using them, you're increasing your type 2 error rate. You're gonna be unnecessarily conservative for all of these. So you try to do it as carefully as possible.
Let's say you have like a clinical investigator who has more like a sort of modeling, tinkering, epidemiology background, and they're like, I want a primary analytic model, and, I want to do a stroke study, but I want to adjust for NIH stroke scale, and I don't know the functional form of the relationship between NIH stroke scale and the outcome. So I won't know how to adjust for it until after I do the study. Like, how do you handle a analytic model that you want for your primary outcome that you don't know enough about to pre-specify?
So I wait for Chris and Valerie and everybody else to weigh in on this as well. I get really uncomfortable in that situation. If you can say you're going to use a class of methods and it's going to be okay, a lot of times if you're just doing covariant adjustments, it's not going to be the end of the world, but I usually would strongly want to pre-specify that nonetheless, just to be sure that there's no p-hacking involved with that. But I could be convinced there's a flexible class of things, so it gives me the heebie-jeebies. Chris?
Well, I mean, the covariate's an easy one. I think I wouldn't worry as much about
Yeah,
that.
covariates are less moving.
I mean, I think it depends on what phase of study you're in, too. If I'm in, like, in Neuromex, we're phase 2, I'm not going to worry as much about that as I would in a phase 3 space necessarily with type 1 error.
I also would get nervous just from what I do for a living. Usually when you start telling FDA, oh, we're going to kind of look at things later and then figure out what to do, it makes them uncomfortable. And with reason. So the FDA, you can spend months and months and years designing your study. They're reviewing it like an hour. They're very sensitive to if you're gaming the system in some way that they couldn't figure out in 30 minutes. And so anyway, you often get a lot of pushback for those things.
Hey, just full disclosure, I'm asking for a friend, like not me.
Okay, chat GPT.
Yeah, we'll be reviewing your report.